Um, it's quite difficult to follow acts such as that, those last few talks, but I'll try my best to match a bit if you want. So all we know that MPFL anatomy is very well described. If you go through PubMed or if you just put MPFL anatomy in Google, you'll get loads and loads and loads of hits. So it's a fan-shaped structure, 46 to 56 millimeter in length, depending on the stature of a person. So Chinese, Asian population is about 46, 49 millimeters, Caucasians 50, 55, 56 millimeters, Indians in between. Since it's a fan-shaped structure, the width is between 3 and 30 millimeters. The attachment is what's more important for all of us, where it's exactly attached. So rather than single point attachment on the femur, the discussion now progresses about a cloud. So there are a few areas where it gets attached on the femoral side. Patella, we all know, is attached to the proximal half, and we all know it's between the layer 2 and 3. I think there is no doubt about that as such. So a couple of papers which show where exactly the attachment is. This is a very famous paper from Professor Justin Cobb, and you can see the fan-shaped structure where it's attached. Those three points which form the triangle are the easiest thing to see in a patient, and you would know where the attachment would be for MPFL reconstruction. Laprade is big name in anatomical dissection of the knee, of course, apart from other parts. But these are very clear anatomical dissections and diagrams that he has come out with, which shows the exact attachment of MPFL in relation to the bony landmarks, which are constant in every patient. Now, what we are interested in knowing is where exactly is the attachment of the MPFL on the femur, and whether we should be following anatomy rather than isometry. So when you're doing a surgery in about flex knee, this is how your knee will look, and that's where the attachment will be. So it's very easy to palpate the medial epicondyle, the adductor tubercle, go between them for getting your MPFL. But as we are progressing, you just heard Roshan asking about MPTL. There's also MQTFL, which is the attachment of MPTL to the quadriceps tendon, which is supposed to be very important. And like a fool that we all are, I tried taking a stitch in the MPFL with the quadriceps tendon, resulting in a very painful recovery for the patient. So I think that's something we should not be, that's something which we should not be trying. It's just a capsular thickening which sometimes shows some attachment to the VMO. Same picture again now this from the Laprade group again. And it's been discussed so many times exactly where the attachments are. On the patellar side, you know, it's more proximal half than the distal half. So the insertion on the patella is more towards the dorsum, more towards proximal half, and it rarely goes beyond the equator of the patella. Now the question is, why do we go for isometric and why do we go for anatomic? Now, important thing to remember is that the MPFL is a non-isometric structure. That's so many papers which have shown that MPFL is a non-isometric structure. So you cannot rely on isometry as a rule to decide where your position should be. What do you mean by isometry? There should not be any change in the length of a ligament with the joint position. So if it's a truly isometric structure, then you can fix the MPFL in 90 degrees of flexion or 0 degrees of flexion. The length will remain the same since it's a purely isometric structure. Now this is a geometric concept, so you're talking of two circles rotating on each other, which is not the case in the knee joint. So the MPFL is non-isometric, so I won't rely too much on that. Shortall's point is very well described. We know about Shortall's point, where exactly the attachment should be. But if you look at the para up here, the radiographical points that you see are not always accurate, and you should not be deciding on radiographic findings or radiographical points to decide where it should be. Moreover, a lot of these patients will have trochlear dysplasia, and the findings are completely different in them. So you need to be very careful when you are using a jig to decide where you are going to go. So I can keep on showing lots of papers, but again one more paper which shows that radiographic landmarks show worst isometric score. So it's very difficult to get an isometric point by using radiography or any other technique that you want to use. So you can see this picture. You can see 4 different points where 2 surgeons felt it was isometric. This is the radiological isometric point, and this is where the isometricity lies between 30 to 90 and 90 to 120, so 0 to 120. So it's quite variable to decide where you want to go. How do I do it? I'll quickly go through it if it's okay. So you find the proximal border of the patella through a small incision. You make a big divot or a big trough on the medial side of the proximal patella to accommodate your graft. I use 2 anchors to fix it on the patella. This is modified sonoricote technique, and it works quite well in my hand. So you put 2 anchors in the patella. Now these are the 3 landmarks. You mark these 3 points in most patients. You can see them really clearly in most patients, and you can indeed see them inside also. So when you feel the 3 points, it's very easy to decide where you want to go, somewhere here. I know you'll be smiling when I say somewhere here, but you need to find the landmarks and make your entry point onto the femur exactly where your attachment should be, which is about 1 centimeter behind the medial epicondyle. When I say behind, I'm talking about a flexed knee and 5 millimeters anterior, 5 millimeters distal to the adductor tubercle. Now post that, you fix the graft. This is a gracilis graft to the, which is attached to the medial patella. I like to transfix the graft, the slight modification I normally do, and then pass between the layer 2 and layer 3. And lastly fix it like that, and that's how your normal MPFL reconstruction look. Now I agree that these anchors look a bit more distal, but if you look at the entry point of these anchors, this is above the equator. So that's how it generally, I would do a MPFL reconstruction. So does it work well? I think anatomical landmarks do make sense, and they're always found. Isometry is slightly questionable and is difficult to reproduce consistently. For ligaments such as ACL reconstruction, isometric reconstruction almost has been given up. So I think I would prefer my tunnel position based on the anatomy as it should be and as it meant to be. We have published reports of my own series with 2 years follow-up. I know it's too less, but with no failures at 2 years. I agree some of them will stretch out, but at least in short-term, anatomic reconstruction does seem to work well. Thank you.
Great talk. Thanks, Bhushan. Please join us here. And now to give the counter argument why isometric is better, let's hear Sabrina.
So I'm probably going to say the same thing, but I think the point that I want to make is that, first of all, it's truly not isometric, but I think through a certain part of the range of motion, it needs to be isometric. And so what I see when I see failures, and I showed several examples of that in my MPFL talk, is when the femoral tunnel is put in the wrong place. As far as whether you do an MPFL or an MQTFL, John Fulkerson, who's a good friend of ours, stopped doing MPFLs altogether because he saw enough complications with patella fracture coming in from the community or cartilage damage that he's gone to 100% MQTFLs, and I think that's an important point, is you just don't want to do any harm. So again, when you see a patient like this with the J sign, this patient does not have normal anatomy. I would bet you this patient has trochlear dysplasia, and once you get an abnormal, once you start with abnormal anatomy, Schottle's point doesn't necessarily work anymore. And I think that was a great point in the last talk. I've been in the OR with Philip Schottle, and when he does his MPFL, he just looks on fluoro and he puts the tunnel in. He doesn't look at isometry, he doesn't feel for anatomy, and I don't think that's the right answer. So again, if you see a patient like this, they're probably not going to have the same anatomic landmarks, they're not going to have the same fluoroscopic image that Philip Schottle had. Here in a CT, you can see how these patients are tracking, and these patients, again, you really need to look at what's happening with that length of the MPFL, especially through the first 60 degrees of flexion. So generally, you want a patient like this. If you're doing an isolated MPFL, you want them to have a normal merchant view and fairly normal anatomy if you're going to not pay a lot of attention to isometry. Here you can see contusion in the lateral trochlea, no cartilage injury. And when we talk about isometry, as was mentioned in the last talk, it's not 2 circles, it's 2 triangles, and it's not going to be the same length throughout. So when I mention isometry, I really mean isometry through a certain range of motion. We actually want to make sure that it loosens once you get to flexion past about 60 degrees. So here you can see, this is my point. Before, you can palpate, you can use fluoro for your starting point, and you put in that pin, but then you want to look at what's happening to the length. And here you can see there's 2 marks on the tendon as it's doubled over. You want to see that it's not really moving when you flex from 0 to 90. And when you get past 90, if anything, you want to see it loosen. You do not want to see that it tightens up. So I think that the most important point of both of our talks is that you need to make sure that you're not over-tightening or over-constraining the knee. Here you can see as the graft is just pulled in, you can set the length. And as I showed on my previous talk, if I can, I like to use a tightrope because that allows me to kind of fine-tune it. I can check my length, and then if I think maybe I want another millimeter or two, it's very easy, much easier than if you use an interference screw. So again, when you look at radiographs, the reason I look at radiographs is just confirming that I've picked the right spot. So I've palpated where I think it goes, then I put a pin in, then I check isometry. The final thing that I look at is I look at fluoro. Is this necessary? Probably not. But we had, at our very first meeting in Chicago, well, when Andreas and I met, we were at the International Patellofemoral Study Group. And so we had a cadaver. It was fully dissected, so there was no question that we had a small incision and we couldn't feel anatomic landmarks. We could feel the anatomic landmarks quite well. And basically, they had each of 45 patellofemoral surgeons put where they thought the correct point was. And we didn't agree at all. So even if we're just looking at anatomy, 45 patellofemoral surgeons couldn't agree on anatomy. We were not putting it in the same spot. So I think the point of that is that even if we think we're putting it at the anatomic attachment site, we may not be in the correct spot, and I think that's a reason why it's probably worth checking fluoroscopy. I used to use a small C-arm. I've gone to using a big C-arm. As we all know, it's really hard to get a perfect lateral with a small C-arm, much easier on a large C-arm. It's also, I think, saves time in the OR. One comment about the distal femoral physis in some of these patients, as we talked about earlier, when they're skeletally immature, we want to make sure that we don't violate the physis. And if you look at the anatomy, generally the teaching is to go distal to the physis. So again, you may not always be at the perfect anatomic spot, and in a patient with significant alta, I think going distal to the physis might not be the right answer. So I think looking at isometry and seeing how it behaves through range of motion is the most important. So spare the physis. Here you go. Here you see a interference screw placed distally. You're angling it distal and anterior, but again, look at isometry. If you don't like how this is controlling the patella, it may not be the right answer. You can also do an MCL sling or go around that adductor magnus tendon. So this is the opposite of what I just said. Before I said go distal to the physis, this is going proximal to the physis. So there's many, many ways to do this, but my point is it really depends on the anatomy and where that patient's patella is sitting, if they have significant alta, and that would be a reason to really look at isometry. So here, a 13-year-old premenarchal, her first dislocation was in kindergarten. She's a 3-sport athlete, volleyball, softball, basketball. And when you ask how many dislocations, it was innumerable. And just looking at this knee in the office, I want to do an osteotomy. You can see how lateralized her tibial tubercle is. I don't care if her TTTG is 10 or 20. I want to do an osteotomy, but I can't. So here you can see apprehension. You can see she's sitting lateral in full extension. She has a jumping J sign, a small effusion, full range of motion. Here you can see on the left that's an open physis, on the left, on the right, a patient with a closed physis, but this patient, fully open physis. So in this case, I would use suture anchors on the patella, a suture anchor on the femur, and I would check isometry, and I would also tell this family that most likely you're going to be back. You're going to operate on her again once she's skeletally mature, because I think in this case you're probably not going to get away with just an MPFL with this much deformity. So you can see the post-op axial MRI image looks fine, but you can see that de jour D trochlear dysplasia. I don't think this is going to last for the duration, and we'll see what the 5-year outcome is on patients like this. So thank you very much.